We move to the next talk, which is Inside Out Story of Contact Dermatitis. To chair this session, I would like to invite Dr. R.N. Dutta sir and Dr. Vinay Shankar sir. Dr. Vinay Shankar sir has joined us on web, and Dr. R.N. Dutta sir, please come forward to chair the session. Dr. R.N. Dutta is presently affiliated with Columbia Asia Hospital, Kolkata. He has more than 36 publications and more than 100 presentations. He has been past professor and HOD of IPGMER and SSKM Hospital, Kolkata, and chairperson of Aesthetic Asia Conference. Past National Vice President of IEDVL, National President, Indian Association of Leprosy, past National President of IESSTD and AIDS. We welcome you, sir. I would also like to invite Dr. Bum sir to chair the session. Dr. Vinay Shankar sir has joined us to chair the session. He is professor and head of Maharshi Markandeshwar Medical College and Hospital, Solan, Shimla. He has done post-graduation from AIIMS, New Delhi, and has several national and international papers to his credit. He has also been awarded WHO Fellowship in STD/AIDS at University of Washington, Seattle, USA. I request you to chair the session, sir, and invite the speaker for this session, Dr. Manoj Singh.
Thank you. I am really happy to see such a nice gathering in such a beautiful hospital, all organized by our none other than Dinesh. Anyway, I think we are running short of time. We are lagging behind 30 minutes. So I request Dr. Manoj Singh to come up and speak on inside out story of contact dermatitis. Manoj.
Thank you, sir. My Sada Pranam to Professor Pasricha, who has been a long-standing guru to me and to all of us. And thanks to everybody in this team. Is the PowerPoint visible?
Yes.
Yes, yes. Thank you. Yes. Okay. Right. So I have some slides on the clinical features and etiology and so on and so forth, which not really modesty, but I'm scared of presenting these before all of you because this is exactly what you have been working on. And I would like to start from here. Why is a biopsy indicated? Why does a dermatologist need a biopsy in cases of allergic contact dermatitis? There are certain specific scenarios. In erythroderma, when you are looking at this and you want to exclude psoriasis, in the palms and soles where the features may be common, may not be common, and to exclude lymphoma. Cutaneous lymphoma, again, can be a slow onset and progress disease, and at times may cause a diagnostic confusion. And then lichen planus hypertrophicis. The most important reason I would say, and what we have seen in our institute, is to document the diagnosis. Because unless and until you are able to pin down that this is the exact cause of allergy or the reaction, that there is a specific contact which is causing this, the features may be, confusing. The features may be of long onset, and it may be necessary in the progress of disease over the years to do several biopsies. And comparing these biopsies at times may be helpful. And this I am speaking specifically of the cutaneous lymphomas. Again, these are pictures which actually are from Dr. Ramam, and you people are experts in these. So I'm going to really skip over these. I'd just like to mention one particular observation which we make. Well, maybe I'll come to that a little later. This special features, histological features in what dermatologists like to confuse the pathologist with the terminology: contact dermatitis, allergic dermatitis, eczema, eczematous dermatitis, acute eczema, airborne contact dermatitis, and so on. The special features are actually epidermal. Now, this is especially seen in uh, uh, acute diseases, and you see a spongiosis, which is an edema of the epidermis, and a varying amount of inflammation. The extent of the inflammation and how much the inflammation is going down will actually be dependent to quite some extent on the duration of the disease. One specific feature which you might uh, 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 like to note, which we comment on, is the fact that when there is an extraneous cause of the contact dermatitis, the upper part of the epidermis is relatively more involved than the lower part. And this feature is going to keep coming out in some of the pictures which I am showing, that when there is an exogenous, of course, there will be all this reaction here, because it is after all an allergic reaction. The cells of the immune phenomenon will be involved from here. But if there is an acute onset or an acute progression, the upper dermis, epidermis will also show significant changes, which may at times be used to indicate uh, 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 a contact dermatitis for some reason. And as you can see here, if you give these slides to pathologists without any history, most important issue will be of lichenoid reaction. Here you have an ongoing disease for some time. You have pigment incontinence, where the epidermis has been eroded and then has healed, as you can see here. Pigment incontinence may be seen in later lesions. And as I was saying, significant involvement in the upper part of the epidermis is an important observation, where the pathologist makes, and it may be of help to the clinician. The other features are really not very specific of anything. There is a lot of edema in the epidermis, inflammation going into the epidermis, variable amount of inflammation in the dermis. And here, actually, in an acute reaction, you may even see an intraepidermal bulla. And again, as you can see here, the prominent involvement is of the upper part of the epidermis, as you see here, in an acute reaction. And again, I skip over these because these really are your areas. I'd just like to go, well, you saw that pigmentation. That again is one of the features which we'll see is very nicely on the pathology, that there is hypertrophy of the epidermis, the so-called acanthosis, which usually is irregular, and there is pigment incontinence, hyperpigmentation and marked pigment incontinence. So that is again a feature which correlates with the given clinical appearance. And once again, the extent of the disease, which you would anyway be evaluating and telling us about, would also help, and some of the histological features would help us to distinguish this kind of a group of diseases from psoriasis. And as you've seen in all these pictures, histologically, cutaneous lymphoma may be a very difficult issue to exclude, which is why at times you need multiple biopsies, and in some of these cases, immunohistochemistry may be of help. And we have been talking a lot about eosinophils as part of the allergic reaction or the immune reaction. as not really so, because eosinophils may be a part, but if you are looking for eosinophils as, as a diagnostic criterion, no. There are many cases, many cases where you do not see eosinophils. And the eosinophils which may be present are the usual 2 to 4%, which are, non-specific or not really a great part of this phenomenon. Thank you. I hope I was on time. Yeah. ओए क्यों है नहीं मैं तो सुनाई दे गया बट वो क्यों नहीं सुनाई दे ये क्या हुआ है
Hello.
Yeah, okay.
Yeah,
now.
thank you, Dr. Singh, for a lucid presentation and a very in-depth presentation of contact dermatitis. Dr. Vinay Shankar, are you there? Dr. Vinay Shankar? He's in net mein hai na?
He had connected in between, sir. Maybe there's been some problem in his connectivity.
Anyway, I wanted him to conclude the session, but let me do it on his behalf. Because there's a lack of time, any question and answer you can fix it later. And I end the session over here. Thank you all for this opportunity. Thank you, and we end the session.
Thank you, sir.
Thank you, sir, for such a wonderful talk. I would also like to thank our chairpersons, Dr. R.N. Dutta, sir, Dr. R.A. Bum, sir, and Dr. Vinay Shankar, sir, for chairing the session.